This is your Pain Game podcast, where we talk about the game of living in and with chronic pain and trauma, getting to the heart of how to heal. I am your host, Lyndsay Soprano. On this show, I plan on discussing with doctors, chronic pain patients, holistic practitioners, loved ones, and anybody that is interested in having their voice heard in the chronic pain and trauma world that we live in. All right, intimacy. Sweet, sweet love and intimacy. What a scrumptious little topic to talk about today, until it isn't as scrumptious as it used to be. I am incredibly grateful that my sex life is scrumptious, but I can say that it isn't without challenges. And now that I'm getting older, and of course, coupled with perimenopause and my CRPS pain, sometimes it's harder to hit the sheets than it used to be. I mean, we work really hard to keep those little bastards out of the bedroom, even on days that I can barely walk, but I am in it to win it. And intimacy is so incredibly important to me and my sweetie as a whole, but it's also important with all of my relationships because I'm a deep feeling chick, sometimes to my demise. But if you're challenged in the intimacy department due to hormonal changes, perimenopause, menopause, trauma, and or all of the above, general pain with sexual intimacy, I have the best guest on the planet for you today, at least in my opinion. My guest today is a board-certified OBGYN, practicing for 29 years strictly in gynecology out of his beautiful space in Burbank, California. He helps his patients with the entire spectrum of gynecological care, including surgery, but his special focus is on the menopause transition and the unique issues that come up during this phase of a woman's life, including pain with intimacy. So he's going to touch on a lot of these different topics. And one of the things that I love about Dr. Rabin is his bedside manner. And how do I know this? Because I'm his favorite patient, of course. Or at least one of them. Of course, my words. But women do not like necessarily going to their OBGYN appointments, right? It's uncomfortable. It's incredibly vulnerable. But with Dr. Rabin, I can tell you that I'd rather go hang out with him than any other doctor or dentist, for that matter, on the planet. He makes me feel comfortable and safe, and also literally has stitches every time I see him. Now, I am a depraved personality type, so, I say things that, I might not necessarily say to another doctor. But his sense of humor, coupled with his gentle care, makes visiting him a joy. And someone that has dealt with sexual trauma, it tends to be hard to go to these kinds of appointments, but not with him. And like I said, his bedside manner makes me feel safe. And as I've mentioned on probably every episode, safety is a huge issue for me. He makes me feel incredible and safe and pretty much makes me laugh. And another thing that I love about him is that he is easy to talk to. You can be open and honest with him about your physical issues, your pain. And I mean, he's kind of like a vagina therapist. And the first appointment that I met with him years ago, he said the funniest thing to me and something that I'll never forget. He's holding his face right now, and I love it more than anything because he knows where I'm going. It's like, it's nice to meet you, Linz. Let's have a little snatch chat. And snatch chat, I mean, I'm dead. I immediately feel safe, cared for, and my worries were washed away. And I've told him, in fact, right before the show, I said, I literally would fly across the globe to see you. So you can't ever retire, as long as I have a vagina, I suppose. But without further ado, I'd like to introduce you to Dr. Stephen Rabin.
Thank you, Lyndsay, for bringing up my terrible puns and jokes.
Oh my God, your puns and jokes are wonderful. And they're not for everybody, but they're for me because I'm so incredibly depraved. But we'd like to talk today about pain with intercourse, atrophy, hormone fluctuations. One thing that's come up a lot in some of my episodes and the people that I'm interviewing for other ones coming up soon is pelvic floor therapy. And he also has something that he wants to talk about called the Mona Lisa touch laser. Are you cool with us talking about your business and these topics and rounding out any others that are important to you and your practice and your patients?
Oh, absolutely. I think not talking about it is the biggest problem out there.
I agree with that. And all right, so I'm rolling out the red carpet for you.
Well, painful intercourse has a medical word. Of course, we have to have fancy words that nobody has ever heard of before, but the technical word is dyspareunia. Dyspareunia, painful intercourse. About 10 or 20% of women will have it at some point in their life. And it's not just about menopause and the hormone declining at that time of life. There's lots of other reasons and causes for pain with sex. And the biggest elephant in the room for me is that it's either the patient is too embarrassed or worried about being judged to bring it up with the doctor or the nurse practitioner or the PA. But even worse is a patient who gathers up enough courage to start talking about it, and then the provider is uncomfortable to talk about it, not trained, not prepared, not comfortable, or even has their own hangups or issues about the topic. It's a kind of a squishy topic, and yet it's central to most of our lives. Not everybody. Sex is not a central part of everybody's relationship or everybody's life, but it becomes a problem not just for my patient, the person, but also for the person who loves them. And it becomes a couple's problem. And besides it being a pain issue and your podcast, The Pain Game, it sometimes becomes a blame game. And the patient themselves will feel broken or deficient or something's not working, something's wrong with me. And then the partner, for lack of understanding what's going on, will either blame themselves or blame their partner for not being into it, not understanding that sex could even be a painful thing. And it becomes a couple's problem, and it really can erode intimacy and confidence and just the relationship overall. Even though this is just a part of a relationship, it's an important part, and it means different things to different people. So I think it's important that a patient be comfortable, like you were saying, to bring up topics that might be uncomfortable, or if you feel unsafe to bring them up, or it brings back old memories. But it's an important topic to bring up. And there are diagnoses and treatments, and there's ways to test for it. And it's not just all in your head.
Well, I like that you say that it's not all in your head, because a lot of women, we get accused, and this isn't just in the gynecological department, but, oh, we're in pain, we're in this, our bodies are so incredibly magnificent, and they're supposed to all work together with all these different pieces, including nutrition and mental wellness and all of that. But man, it's a struggle to have doctors like yourself know that you're not making this up. Why would I make this up? Why would I dream this up? But having someone like you who is so comfortable to talk to, where I can say whatever the hell I want to you, and you take it, and you're straight up. You're like, all right, well, maybe you should stop doing this, or, or maybe this would be a better idea for you, Linz, and having those practitioners in your world and it's hard to find. It's hard to find a you. And I mean that with all of my heart. It really is, because I've been faced with it. I've had this little vagina for some years. And you're the only, well, there's two people I trust with that. You're the only other guy. So what I'm curious as to see, what age do you start seeing, at least now? I know that I think it's changed with our nutrition and our lives and our stress and popping out babies and all of those things. There's all kinds of, but when it comes to age, when are you seeing this painful intercourse? When is it starting in women nowadays? I'm just curious.
Well, going to the root causes of it, there's physical factors, there's hormonal factors, there's medical conditions, and there's psychological factors. And these can happen at any phase of life. It could happen with a young woman at her first sexual experience. It can happen after you have a baby and you're breastfeeding and there's some really funky low hormone levels at that time. And then it can happen in menopause when the hormone levels drop and there's the vaginal dryness and atrophy. There are conditions that have nothing to do with age, having sexually transmitted infections, having fibroids or endometriosis or scar tissue and adhesions from a previous surgery. So there's such a long list of things that can cause pain with sex. Many, many, many patients come see me because it's part of the menopausal transition. And that's a time when women seem most comfortable to talk about it. But it's something that, we bring up at all visits. Birth control pill use can actually lead to some vaginal dryness and atrophy. And sometimes we can see it on a physical exam, but sometimes you have to ask, are you having any pain or problem with sexual activity, with enjoying sex? There are some conditions where, because of the past pain, the pain actually compounds consciously or subconsciously because it becomes a learned response. This is going to hurt, therefore it's going to hurt.
Sure.
And, the body will do that to protect itself, knowing that doing this hurts, therefore I shouldn't do that. Therefore I need to, respond to it as a pain thought and a pain feeling. And that could be either prior abuse, but it could just be from the prior dryness or a skin disorder. But there's definitely that mind-body connection. So there is a place you were mentioning for pelvic floor physical therapy, but also sometimes a sex therapist, because there's the mental aspect of it, which could be the total origin of it. But even if you have a legitimate, recognized, diagnosable skin condition, let's say something called lichen sclerosis, which is underdiagnosed. It's a skin condition of the vagina where the tissues become very white, like cigarette paper, and they create fissures, and it's an awful, painful thing. And doctors who don't pay enough attention to it and don't consider doing a biopsy of the skin will just call it a yeast infection or vaginal atrophy, and they'll either throw Monistat at it, diflucan, or estrogen cream, not really getting to the root cause of what it is. So it's interesting that there's definitely the mind-body connection, but I think the problem has to be addressed by first the doctor taking a very good history, seeing when it started, under what circumstances. Was it when you started having sex? Was it after some painful episode of sex? Was it after childbirth? Was it because you've been on birth control pills for 20 years? Is it because you're in menopause? The history of it gives us a lot of clues. And then a physical exam. And it's more than just looking at things. It's actually collecting some samples or making a slide of the vaginal skin cells under the microscope. They tell a story. Making sure it's not an infection. Doing a pelvic exam and figuring out, does it hurt here? Does it hurt here? Does it hurt here? It makes me sad that it's hard, that you said it's hard to find somebody who takes this seriously, because it's stuff that we learn in medical school. It's just, we learn everything, a little bit of everything. And it's what you take with you into your practice, and you kind of hone those skills and make it part of your routine. I'm not looking at people's tonsils anymore, but we all learn how to do that. But you would think that a practicing OBGYN would take this seriously and get to the root cause of it. But time and time again, I'm the third or fourth doctor somebody comes to. And what seems to me to be just a simple, straightforward, I'm going to do A, B, C, D, and it reveals something that has a fairly straightforward and simple solution, the patients are, they're crying. They're like, why didn't the first guy do this? Why didn't the first lady doctor do this? Why did the second?
Why didn't the third? Yeah, no kidding. In fact, I had a girlfriend that did an episode with me, and it took her 5 years to get diagnosed with what we call the pain in the ass, because I can't pronounce it to save my life. What is it?
Proctalgia fugax?
Fugax. Yes. Thank you. Gosh, that's a hard one to say. But she went through the same thing. Like, I went to every doctor. I went to all these doctors, and it finally came down to this one that was like, have you thought about this? And she was like, wow. Okay. I've been talking. And she's one like, that's me. She's open, she's honest, and she'll talk. But one of the things, I had another interview with the doctor, Dr. Deepak Rabin, who talks about the trauma-informed approach to healing and how he asks questions, just like you're talking about. Like, somebody might not be as open and like free, wild spirit like myself to come in and just like say whatever, but you know the right questions to ask because you care. And that, I feel, is and it's unfortunately, it is a thread that is going through this show, and it's a thread that's going through pain, because I consider to have pain like what my girlfriend had to be chronic. I mean, it was 5 years of it to find no help, And so thank you for being the kind of doctor that you are, that, that does ask these questions, that does probe into, no pun intended, I know it's hard for me to not, but probe into, this could be an issue of something that happened to you so long ago, or this, that, and the other thing, like you were mentioning. So thank you for being that guy for us.
Well, and it also, when somebody has already seen a bunch of doctors, you feel the pressure.
Sure.
And sometimes I don't have the answer, and that feels like a letdown. But we try. I think in most cases there is a root cause and there are some solutions, and you have to have a plan A and a plan B and a plan C. And I can come up with the best approach I think is going to work. And sometimes the patient's not comfortable with that, or she just doesn't want to do that. And that's okay too. You have to work within somebody's willingness to do things. There's a simple therapy that pelvic floor therapists will bring up all the time when patients have a vaginal tightness where they can't accommodate their partner, where it always feels like it's too much, where the tissues, no matter how much lubricant you're using, it still feels like it's tearing or ripping. And it's such a simple caveman type of mechanical solution, and that's progressive vaginal dilators. And it's just a set of 5 or 6 phallic looking candlesticks, I call them.
Yes, I know
that are
what they
tapered
are.
at one end. And, we have sets of them here for the patients. Of course, you could buy everything on Amazon nowadays. And explaining it to patients and explaining how if you work through these, and it might be several weeks before you move to the next size. And at least half the time, patients look at me, you've got to be kidding. You really expect me to do that? That looks awkward. That looks stupid. I want a pill. And
big pharma for the win. Well, is it because they think that it's maybe because they're not like into using, like toys in the bedroom, that it feels a little bit more uncomfortable for them because it's more in the sex toy looking department, even though it's really just a health aid to make you feel better?
It could be that. It could just be that it is a lot of work, and it is being more in tune with yourself than maybe somebody wants to be.
Yeah.
It does include pushing yourself to the limit of where it hurts and trying to take yourself beyond that. But who better than you, under your own hand, under your own control? And what some of the fringe benefits of using progressive vaginal dilators is that you also can gain the confidence that once you're at a particular size that maybe seems to approximate your partner, a match. Honey, you're of number 5.
Honey, you're a number 5. Congratulations. Bravissimo.
But having the confidence to know I can handle that, it can kind of beat that mind-body game where you'll say, you know what, I can handle that because I did that. I even can do a little bit of number 6. And to be more confident and comfortable in trying again to have, sexual activity. And this, along with some other techniques, are some of the things that a pelvic floor physical therapist, a very special kind of a physical therapist who does go down there and does do some intravaginal work, identifying what muscles are perhaps, in spasm and need to be relaxed, teaching somebody how to connect from their head to those muscles to actively relax them. Because, we're passively tensing them up. There has to be an active relaxation, which is not usually how people think about relaxing. People think relaxing is just not tensing anymore, but there's really a proactive way of letting things relax. And it's a learned experience of connecting to those nerves that control those muscles down there.
For sure. I mean, that's like we all hold our stress in different places, and if you're one in your brain that already is stressed out, that sex going to hurt, or it's going to make me feel like it's tearing, or I'm going to be dry, or what have you, you're immediately going to get squeamish and be like, whoop, forget that,
But it's a survival mechanism. I mean, our bodies are wired to avoid things that hurt. So it's a hard thing to overcome. And I think that by physically doing something like the progressive dilators, where you can get confident and train your brain to say, oh no, I can, look. And so hopefully that works on a physical, anatomical basis, but also on the psychological basis. That involuntary spasming and tightening of the vagina also has a medical term. It's called vaginismus.
Ooh.
And it's usually we think about it from past sexual trauma, but it can just be from vaginal atrophy or having undiagnosed herpes outbreaks or having, like I mentioned, this lichen sclerosis skin condition. So it's important for you and the doc to get down to a root cause, do the tests that make sense based on your history and based on what they're seeing and feeling, and working on that root cause. For me, I tend to attract a lot of patients who are entering that perimenopausal transition, and that age can range anywhere from the early 30s until well into your 50s. Menopause is defined as your final period. And you only know it's your final period when it's been a full year of having no periods. We don't wait a full year to treat somebody, but that's the only true definition of menopause, is that you've stopped having your periods and it's been a year. There's lab tests that help us. There's obviously the symptoms and the hot flashes and the night sweats. A lot of those things go away with time. The hot flashes, the night sweats, the trouble sleeping, whether or not you use hormone therapy, most of those things eventually go away, except for the vaginal atrophy, the dryness, the thinning, the more fragile nature of those tissues. That's the one menopausal symptom that does not get better with time.
Sure.
And it can start way before hot flashes and night sweats. I mentioned that it can occur with prolonged breastfeeding. And it's kind of the last thing anybody would think of, because you're
not at all
20 or 30 years old and you're not thinking, atrophy. That's for older people, you think. Prolonged birth control pill use. Birth control pills do a lot of really great things. And there's a couple of things that are not so great, that they can create a problem with the very thing that you're trying to make sex easier, with less fear of pregnancy. Yet it can make you have a lower libido, and it can create a vaginal dryness situation. And so all of these issues have very specific treatments. And in that treatment world, there's lots of options for people who are able to use hormone therapy and for people who are not able to use hormones. We have to have a lot of tricks in our bag.
Yeah. And so you had mentioned, I know you've talked about, labs and testing, and there's moisturizers, there's creams, there's all kinds of different things, some of which you've given me and I've tried. And cause I'm old. And I'm in the middle of that spectrum, I'm 44. So I'm like, okay. So can you talk to us a little bit about this Mona Lisa touch laser? Because I'm very interested in this.
So when we're talking about vaginal atrophy, the root cause is the lack of estrogen, and the tissues become thin, more fragile, less elastic. The vaginal pH changes, and you can be more prone to infections. And the main treatment for this is estrogen therapy. It could be systemic hormone therapy if you're also treating hot flashes and night sweats. But if it's just a vaginal issue, the main treatment is local vaginal estrogen cream or tablet or ring. And that works 80-90% of the time if somebody is persistent and comfortable to do that. And not everybody is willing to stay the course and work with it. And there are folks who are told that they're not allowed to use hormones. Sometimes people with clotting disorders or people with estrogen sensitive cancers going on, they're told to stay miles away from hormones. And although some oncologists and hematologists will allow the local vaginal estrogen, as a generalization, people are scared as hell to use estrogen when they've had an estrogen sensitive cancer. That's understandable. So for me, we've lacked an option for people who are either not comfortable to use hormones, or they're told not to use hormones, or the subgroup of patients who have used all the hormones in the world and are still having vaginal dryness and pain and loss of elasticity. It turns out that in 2008, some urogynecologists in Italy took the same fractional CO2 laser therapy that's been done on the face and the neck for decades, and they said, let's put it in the vagina. That's my Italian. And,
Buongiorno.
And so they created a probe that looks a lot like a vaginal ultrasound probe that delivers the laser therapy inside the vagina.
Oh, interesting.
And we also have a different scanner head that helps do it also on the labia, the entrance, the vestibule, we call it, and the labia. So what it's doing mechanically is a lot like microneedling, which goes all the way back to Egyptian times and is making a huge comeback in aesthetics. But the idea of creating these micro injuries and stimulating the body's own healing response to bring in new collagen, new elastin, new blood vessels, and to create this thicker, more elastic, moisture-producing skin, which is something we never thought would be possible without hormones. So it's a non-hormonal approach to help the atrophic symptoms of menopause or prolonged breastfeeding therapy or the birth control pill use. And so this is a new tool that we didn't have. It became FDA approved in the US late 2014. I was literally the third person in the country to invest in one of these machines and became one of the trainers in the US. So doctors would have to come by here and spend half a day. I would bring a couple brave patients in and they would get paid to help participate in the training program, but it was fantastic that there's a bunch of doctors, not a lot, but in most major cities, you can find somebody who provides this kind of therapy. And because the Mona Lisa Touch fractional CO2 laser has been so successful, and there have been 30 medical papers written about this. And so there's some other companies that have also had the facial lasers, and they said, well, we can make a probe also. So I can't say that any of their machines aren't as effective, but I can tell you this is sort of the gold standard, and this is the machine and the device that all of the research and the papers, it seems to be the one. And I'm glad that that's the one that I got into. It's a series of 3 treatments that are 6 weeks apart in the first year, and then a single treatment once a year for maintenance. It takes about 6 to 8 minutes to do it. And we do put some numbing cream on the external portion before we do the procedure. So it's a 30 minutes, from start to finish of an office visit, and very little downtime. We ask patients to wait 7 days to have sex. But even after the first of the 3 treatments, people are noticing improvement. After the series of 3 treatments, about 90% of patients are finding improvement in both the genital symptoms of menopause, the vaginal dryness, the pain with sex, but also urological symptoms that are related to that, including urgency and overactive bladder, and even a little bit of prolapse. It helps the elasticity issues. So I've had urogynecologists refer patients to me to do this procedure before they consider doing other more extensive surgeries for these same problems.
So, I think I know what the answer is going to be, but does insurance help cover any of this?
The Mona Lisa Touch procedure is not it is FDA approved for gynecological use. It is not covered by insurance. We still see patients able to use when they have a medical savings account or these flexible spending accounts. We do send charges to the insurance, and it may actually count against their deductibles.
Okay. Well, that's better than nothing.
It is. And so, yeah, it's not covered. And we've had patients from all walks of life figure it out. And we do, for instance, here we use Care Credit, and they have a period of time to pay it off with no interest and things like that, or just using your credit card and figuring something out to pay it off over time.
Yeah, when it comes to, I know with my bod, I've spent like hundreds of thousands of dollars to keep me out of a wheelchair, which is not deemed to have worked thus far. But we pay so much money out of pocket for some silly things like acupuncture, for example, on some insurance plan, things like that. And so it's really hard to go about taking care of your body with insurance, because a lot of the ways that we want to do that are a little bit more holistic, that aren't being pushed and moved around with big pharma and drugs and all of that, because our bodies are so sensitive. Mine specifically is, and that even, but like I cannot take a lot of medications at all. My body is just too sensitive. So I go about it in ways like the Mona Lisa, for example, which I'm like, okay, I'm going to have to book this guy. And I've been wanting to talk to you about it for a while. Actually, I just haven't brought it up. So it's a better time than now.
I'll also tell you, though, I think that it's important, especially when doctors have these procedures that are more expensive, that everything's been exhausted. You've kind of moved through the steps. You've tried the things that are, even when that estrogen vaginal cream isn't covered, with these good RX coupons, it could be $30 a month, actually $30 for a 2 or 3 month supply. So there are very entry level treatments and procedures and the dilators that are very accessible to everybody. And I don't even think those are being used to their full potential. And I always save these things that might not be covered. I'll talk about them in the upfront. Because some patients are like, I don't want to use hormones. I don't want to use diet. I don't want to do this. Those that do get treatments like Mona Lisa Touch, I still ask them. I'm like, let's do a 360-degree approach. Let's not just depend on one modality. It's like if you're having pain and you want to use over-the-counter, maybe you'll do Tylenol and Motrin, and just they're different families, and they may work synergistically. So I ask patients to continue to use the dilators, their vaginal estrogen, and Mona Lisa. And we see a really high response rate when people are dedicated and motivated and diligent to sticking with the program. It sometimes takes a lot of work to be and feel well.
It's a full-time job over here. That's for sure. But it is one that I am dedicated to. And you're right. Like if you come in with the mindset that you're going to leave feeling the same way you did without putting in any effort, then I don't even know what to say to those kind of people. Like if you're just expecting like miracles to happen as soon as you walk through a door, you're not, that's completely unrealistic. But I love that that you've got so many different types of solutions and treatment plans. Like you said, you got to have a plan A and a plan B and a plan C. And I'm so glad they are multiple, because I feel like for most doctors, well, and I know this at least in the pain community, where it's like, well, have you tried gabapentin yet? I'm like, what the hell do you think? Of course I've tried gabapentin. Everybody I know has tried it, and it works for a very small percentage of people in my world. And so I just thank you for even offering other suggestions. And I think it is that the mind-body connection is so incredibly powerful. And if we just gave ourselves a little bit more kudos for what we're able to do, with our brain. Have you read the book, The Body Keeps the Score?
No, but I can get what it means just from there. I like that. It's
an amazing book, and one that I've read it. I'm on my third round of reading it, and I take something each time just a little bit more different away. And I feel like if I had read that chapter 2 months ago, it wouldn't have even affected me the way that it is now. But it is definitely worth a read. I think you specifically would really appreciate it, just because it matches your approach to everything, So, okay, well, is there anything else that you want to chit chat about in relation to our BODs and your practice, and anything that you want to leave our listeners with?
Just a couple of points. There's a couple of different kinds of pain with intercourse. There's pain on entry that can have to do with friction or tightness, or infections or skin conditions, and that should be differentiated from deep, penetrative, collisional dyspareunia, where deep inside there may be fibroids or ovarian cysts or things like that. So it has so many moving parts to it that it would be a visit all by itself. It's kind of difficult when somebody comes in with their annual exam and 3 other problems and 4 other refills, and then they want to open up the door to this. It really deserves a full attention, full visit, and explore all the different options. The other thing I wanted to mention is that some of the over-the-counter approaches when sex is painful, there's a difference between sex lubricants and vaginal moisturizers. And there are products out there that are meant to be used twice a week, just like you would use, hand cream or something for your hands and feet, just to keep the skin healthy and supple and moist. There are specific vaginal moisturizers that aren't necessarily used during date night. And you can find them over the counter, products like Replens, OBGYN, and an internet sold product called Reverie, which has hyaluronic acid, which so many of the skincare products have. It's what's in our joints to make them slippery. So there's a lot of natural things that are safe to use twice a week as just a vaginal moisturizer. And then for the sex lubricants that are used on an as needed, when you're having intercourse, keeping it as bland and plain as it can be. None of these, scented or his and hers, and they get together and they have a chemical explosion. And so just a very plain silicone-based or water-based. There's a favorite product that we recommend patients get at Target. It's called Wet Platinum. And they have a water-based and a silicone-based one. And then patients will find that sometimes, despite all the slippery stuff, it still feels like it's tearing and ripping and stretching. And that's when it's time to come see the doctor. Make sure you don't have one of these funky skin conditions down there. If it is vaginal atrophy, just to go stair-step through the different approaches, whether it's local estrogen therapy, local DHEA therapy, progressive vaginal dilators, pelvic floor physical therapy, or moving on up to considering something like the fractional CO2 laser. The Mona Lisa Touch procedure is always in our back pocket when the other options aren't working.
Well, that's all great information. Especially, I'm glad that you made it clear between lubricant and moisturizer. Because when you think lubricant, you're like, oh, it's going to make me moist. No, it doesn't. Not long term. So I know that you've got, I'm going to put this stuff in the show notes, guys. Everything you talked about, even our medical names for, things that I didn't have for, painful intercourse and so on and so forth. And he is creating a separate page specifically on his website that I'll put in the show notes. But his website is www.gyn and the number 1.com. And then I'll put our page specifically in there once I have that from him, just to make sure that it's up and running and what have you. He also does have a 20-minute webinar that you guys can watch about his practice and his care. I'll also put that in show notes and in social media as well. Anything else for us today?
No, the website, I'll put it up this weekend, gyn1.com/pain game.
Oh,
easy
perfect.
to remember.
Oh, that's very easy to remember.
Yes,
I play this game every day.
gyn1.com/pain game.
Perfect.
And we'll put some goodies there for your audience.
Oh, that's very sweet of you. Thank you. I really appreciate you taking the time with me. I know we're usually a little bit more wacky with each other, but not everybody is as crazy as me. So you are exclusively invited to share this VIP vagina pain journey together. Let's get to the heart of how to heal with you by my side. Please follow the Pain Game podcast wherever you digest your podcast content. We will be there. Visit us at thepaingamepodcast.com and follow us on all the socials. And don't forget to rate, review, and subscribe. Very important. Thanks for listening, my little VIPs. Catch you on the other side.